Good evening. I'm Dr. Travis McCoy with Piedmont Reproductive Endocrinology Group, and we're here on this Facebook Live to discuss about PCOS, or Polycystic Ovary Syndrome. We're going to just take a minute to confirm our connections in our live streaming. Okay, we are good. Well, PCOS is one of the most common female endocrinologic disorders. A lot of estimates place it at about approximately 17% of women can have this disorder. Many women have been diagnosed. Many women are given the assumption that they have it without being properly tested and treated. And many women have it and haven't really bothered to bring up that issue with one of their physicians or other providers to figure out if that's really what they have. Along this presentation, we're going to talk about PCOS, what it is, its incidence, some of the complications that can develop from it long-term in medical management, as well as then we'll get into the fertility aspect of its management. PCOS has been defined in several different ways. The mainstay definition is that it involves a woman not ovulating and releasing eggs on a regular basis. If a woman does ovulate and release eggs on a regular basis, then she will have very regular menstrual cycles. The opposite is also true. So if she is having very irregular cycles, then she is definitely not ovulating on a regular basis. And PCOS is the number one cause of having irregular, non-ovulatory cycles. But the criteria are having irregular, non-ovulatory cycles, excuse me, and also having evidence of having excessive male hormone production. This is one of the hallmarks of PCOS. The women don't ovulate regularly, and they overproduce some of the male hormones. Testosterone is one that people have heard about. It's one of many different male hormones that are there. In some of the older criteria also used ultrasound findings, but we tend to not rely on that. There's issues and debate about whether or not that should be included, but ultrasound does not come into really the diagnosis of it. And that's mainly because many young, healthy women have ovaries that fit the definition of PCOS, despite them having no problems whatsoever. So the mainstay is excessive male hormone production and irregular cycles. I have a slideshow that just kind of walks us through a little bit about this. And so I'm going to pull this up. So PCOS, or Polycystic Ovarian Syndrome, is a disorder where the ovulatory signal that goes from the brain to the ovary is disrupted. So this signal is irregular, and when a woman does not ovulate on a regular basis, you can see the ovaries take this form of what we call polycystic appearance. These follicles, these are small, what we call antral follicles. These were eggs that started to develop, and partway through their developmental process, they were never given the proper signal to fully progress and fully mature. So these follicles just kind of hang out until they eventually die. So there tends to be a stockpiling of these follicles in the ovaries. So hence where the name comes from. When you look on an ultrasound, you see a lot of these very little cysts. Now, these are very different than where a woman will often refer to a different type of cyst. And the polycystic appearance can come and develop with any type of non-ovulation, not just with PCOS. But many young women who have very high-functioning ovaries can have a very similar appearance. But the mainstay problem is having this disrupted ovulatory signal. In the vast majority of women, this signal has been disrupted from puberty. So they've always been that way and always will. When they are not ovulating regularly, this signal tends to promote the production of excess male hormone from the ovaries. Male hormones come about 50% from the ovaries and about 50% from the adrenal glands. And so there is an overproduction of these male hormones. In many women, as they overproduce male hormones, this can lead to something called insulin resistance, which is a very mild pre-diabetic tendency. Now, the ability and the extent of this depends a lot on whether or not a patient is overweight or obese, and it also depends really strongly on family history. But in this situation, the body makes excessive levels of insulin. Well, one of the side effects of insulin, when you give insulin, insulin directly stimulates the ovaries to make more testosterone. So the more testosterone, this worsens the insulin resistance, and you get into this vicious cycle. And there's several of these vicious cycles in PCOS that all feed off of one another. Excess testosterone can lead to the development of acne in some women. Over time, it can also stimulate hair growth, which is termed hirsutism. And this is women developing hair growth in what we term a male pattern. So in places, I usually say in places that women don't want to have hair. So you can develop hair on the face, on the chin, on the neck, on the sides of the face, the upper lips, and then you can also develop it on the abdomen, often starting in the lower abdomen, marching on up to the upper abdomen above the belly button. It can also develop on the chest, around the breast, and also on the shoulders and back. This excess testosterone also promotes an abdominal fat distribution. And also this leads to abnormal levels of cholesterol in the body. The elevated insulin levels leads to a person being pre-diabetic, and the main risk factor is developing full-blown diabetes over time. And there's estimates that 30% of women with PCOS may become diabetic if they're untreated by the age 30 in overweight women. But the elevated insulin levels promotes abnormal lipids, and all of these promote the development of premature heart disease, as well as favors weight gain. As a person gains weight, they become more insulin resistant. So this is another one of these vicious cycles that continues over and over. And so this often gets started in teenage years, and some of the women can have semi-regular cycles in teenage years, but as they get older and get into the 20s, this really snowballs, and they can start to become more and more irregular. So what do we do about it? The main concern medically is the long-term risk, and that's really the risk of development of diabetes and the development of premature heart disease, both of which of those are a major issue and a major cause of a shortened lifespan. So the treatment methods medically is to try to interrupt this cycle. The mainstay treatment of PCOS is first and foremost using an oral birth control pill. So there are many women that have PCOS that were actually on this treatment to manage their cycles or for birth control, and they were actually doing the best thing that they could for themselves, unbeknownst to them. An oral birth control pill disrupts this abnormal signal from the brain, and this directly lowers testosterone production. Testosterone in the body exists in two different forms. When it circulates, most of it is bound to a hormone that's produced from the liver. And this bound testosterone does not function. So it's only the small percentage of what we call free testosterone that's actually doing all the evil deeds. Normally about 97 to 98% of the testosterone is bound up, and 2 to 3% is free. When we use an oral birth control pill, as it goes through the liver, it stimulates more and more of the proteins that bind up testosterone. So not only does it directly lower testosterone production from the ovaries, it also increases the binding of the circulating testosterone, thereby lessening the free testosterone. In many cases, we also use insulin sensitizing drugs, which are mainly in women who show insulin resistance. Now, insulin resistance really bears a lot of weight on their person's weight and their family history. In general, we know that women with PCOS, some of them can be overweight. Studies have shown that approximately 60% of women with PCOS are overweight, but about 40% are what we kind of term the lean type of PCOS, where they are not overweight, they're more normal weight. And most of the women who are obese definitely have some insulin resistance, kind of by definition. The women who are of the lean type, though they can have a slight tendency to have insulin resistance, it's usually not very severe. So they don't gain as much, the thin type do not gain as much from the insulin sensitizers as do women who are overweight or obese. Some of these sensitizers are metformin. If metformin is not enough in people that are severely pre-diabetic, others include Actos or Byetta. They work by different mechanisms of action. And there's a lot of newer evidence that other chemical compounds, things called myo-inositol and chiroinositol, work to help this significantly. There's been a lot of published research on this just this year that's starting to shift some of our thoughts. But the insulin sensitizers, because insulin is still feeding testosterone production, this helps to lower the insulin levels. Now, in women who have excessive hair growth, that is treated separately. Many women can have terribly elevated testosterone levels and yet have beautiful skin. A lot of that depends on a person's ethnicity and kind of their genetic background. People from a Northern European type, very fair skin, tend to not have as much problem with hirsutism as some other genetic groups, ethnic groups around the Mediterranean, Eastern European. They tend to have kind of an overwhelming response to even milder levels of testosterone. So the mainstay treatments, if a person is not trying to conceive, is first and foremost using an oral birth control pill, which helps suppress the testosterone. And if there is insulin resistance, treating it, which really helps limit the production to full-blown diabetes. Another added benefit of an oral birth control pill is to help her regulate her menstrual cycles. When a woman does not have regular menstrual cycles, there can be an overgrowth of the lining of the uterus. And over time, this can develop into precancerous changes. These can occur at a very young age. And so that's one of the concerns about not having cycles regularly, is that you're not adequately cleaning out the endometrium, and that promotes precancerous changes. So a birth control pill is protective of that as well. So a birth control pill and insulin sensitizers, if they need it, are the mainstay medical treatment as long as she is not trying to get pregnant. If she's having excessive hair growth, we treat that directly with medications that block the hair growth. Okay, getting back there. The medications that we use are a couple. One is a medicine called spironolactone. Spironolactone is an androgen blocker. It blocks testosterone from working, primarily in the level of the skin. And for many women, that can make a significant benefit on top of a birth control pill to hair growth. However, in the skin, your body is able to take testosterone and convert it into a much more potent form called DHT, or dihydrotestosterone. Dihydrotestosterone is about 100 times more active than testosterone to the testosterone receptor. So there's another medicine that we'll often use in people that have more significant hair growth, and that's called Finasteride. Finasteride is a medication that inhibits that conversion to this more powerful, potent dihydrotestosterone. So many times we're using spironolactone and Finasteride together. Even if you magically take away all the testosterone in a person's body, those hairs that have already turned into the male type, coarse, darker hairs, these hairs are established, and it takes them a very long time to respond. Hairs basically exist in 3 stages. They're either in a growing stage, a resting phase, or a dying phase. And depending on the parts of the body, depends on the stages that these hairs exist in. most of the hairs on a person's head, your normal hair, is mostly in a growing stage, but then there's a short resting stage and a dying phase. Whereas hair on the facial hair are usually in more resting, slower growing. The life cycle for hairs to go all the way through these 3 cycles can take upwards of a year to 18 months. And so once the hair follicle has responded to the male hormone and it's become darker, coarser hair, those hairs will stay that way until they cycle all the way out. Blocking the male hormones can definitely slow the growth, and that's one of the first things that we see. Often within 4 to 6 to 8 weeks, patients should see a significant slowing of the growth of the hair. So women who were treating by shaving or plucking find that they do not need to do it quite as often. Ultimately, as the hairs go through the life cycle, the next hairs that come around should come in a little less coarse and a little softer. And so over time, a person can make ground. But the mainstay treatment is really trying to prevent new hairs from getting darker. I tell women that unfortunately, no matter how bad you think it is, it can get worse. And the longer the length of time you're exposed, the worse it'll get. The only permanent relief is treatments like laser therapy, which laser therapy can work very well for women who have fair skin and dark hair. There's a large contrast between the hair and the skin. It does not work very well for women who have dark skin and dark hair because it's the darkness of the hair follicle that absorbs the energy from the laser. So if you have dark skin, you also absorb that into the skin, so it's not as effective. Those patients can also use other things like electrolysis, but it's a lot slower. But I get a lot of referrals for PCOS from one of the hair clinics, in that they have women who've never been diagnosed and they're getting laser hair treatment. But those women, if they do not treat the underlying issue, there are new hairs that are in place that will march in to fill in the place of the ones you're killing off. So you're really fighting a losing battle. So hair treatment is definitely something that no one's died from, but it is a cosmetic issue that is extremely bothersome to women. So the important thing is that they get treated earlier. The earlier, the better. But there's a wide variation on how their body interprets the testosterone, and testosterone levels do not really necessarily correspond with whether or not they will have trouble. When it comes to the diagnosis of PCOS, the mainstay is seeing that they are not having regular menstrual cycles. The majority of women who don't have regular menstrual cycles will likely have PCOS. And I see many, many women that come in and they've been given a blanket statement of, oh, you have PCOS. Now, in many cases, that's true. However, there are some serious medical issues that can mimic PCOS that needs to be ruled out. So PCOS is what we term a diagnosis of exclusion, meaning that there are several important medical issues, and once you've ruled all of those out, if nothing else looks to be the problem, then you say, yes, it's PCOS. So it's the presence of irregular cycles along with excessive male hormone production. That can either be shown up in the blood or evidenced by excessive hair growth. If a woman is having excessive hair growth, I know she has excessive hormones in her blood. The problem with hormone testing, many, many times, a person has a testosterone level performed and they're told your testosterone's normal. And I tell them, no, not necessarily. Women have about a 15th of the level of normal testosterone as a man has. It's such a small amount, it gets to be very difficult to actually measure that small amount. So the test that we use is not nearly as accurate. So what I tell people, that test is helpful if it's elevated, then it's definitely high. But just because it's normal doesn't mean it's not normal. It's not high. It's just very difficult to measure in that low of a range. I explain it to my patients. It's like me taking a thin notepad and using a ruler to measure the thickness of this notepad. I can tell you it's not 2 inches thick, but I can't necessarily tell you exactly how thick it is. And it's just because a ruler is a poor tool to measure this low of a level. And the same thing bears to the hormones. There are other hormones as well. And so some women may have normal levels of testosterone, but other elevated levels of hormones such as androstenedione, dihydroepiandrostenedione, and other male hormones. So the main things that we look for when we diagnose a patient is the medical things that we have to rule out is thyroid disorders. A woman who has significantly low thyroid and to some extent high thyroid can have irregular cycles as well. So we have to rule out a thyroid issue. And then there's another issue, another hormone called prolactin. Prolactin is a hormone that's made in the pituitary gland in the brain. And some people can make an overproduction of this. And prolactin elevations can lead to irregular cycles. It does not usually lead to, nor does thyroid lead to the excessive obvious male hormone production, but it can lead to irregular cycles. The other thing that we want to make sure is the ovaries are still functioning. Some women could have irregular cycles, especially if they were regular before and now are irregular because they're really pushing into the bounds of menopause and are losing their ovarian function. Or if they've stopped having periods, you want to make sure that they haven't completely lost all of their ovarian function. So as long as the thyroid is level is normal, the prolactin is normal, and the ovaries are still working, most likely this is PCOS. We do sometimes look at the male hormone levels, primarily to rule out a super high production issue. In extraordinarily rare cases, testosterone or the male hormones can be overproduced in other places, the adrenal glands or by small tumors of the ovaries. These are incredibly rare. These tumors, there's a very good chance I may never see one in my entire career. It's that rare. But some women can have a genetic tendency, a genetic predisposition this is a different issue called congenital adrenal hyperplasia. And this often mimics PCOS very closely. But they have a genetic issue where they overproduce testosterone, and it will look just like PCOS. And to some extent it's somewhat treated differently, but somewhat treated the same. So the first evaluation when a patient comes in, a lot of women come in and say, I have PCOS. My first tendency from a medical standpoint is, one, so many of these patients were never accurately diagnosed. They were just given a blanket statement, and it's likely true. But I really have to go back and rule out these serious medical issues. Once I have ruled out these serious medical issues, then we can kind of focus on which direction to go. And it really takes a fork in the road depending on whether or not she is wanting to conceive right now. If she does not have any concerns about conceiving right now, then we look at medical management. And then you're looking at optimizing her, trying to control her cycles to prevent the development of uterine cancer. And so the simplest way to do that is a birth control pill. There are some cases where, for other reasons, we can't use a birth control pill, and there are other options. So an oral birth control pill is really the best. You can also use NuvaRing. NuvaRing has been found to have a similar effect as a birth control pill. Some women use an IUD. An IUD does help protect the uterus. A Mirena progesterone-containing IUD does help protect the uterus. It does not, however, help the metabolic issues throughout the body. So I tell patients the three most effective things you can do for PCOS is pill, pill, pill. So an oral birth control pill is the mainstay blanket treatment to help. The idea is to lower the testosterone as a first step. If she has abnormal hair growth, then we will address that separately. But if she does not have that, then those medicines, spironolactone and finasteride, do not need to be used. Then it's more looking at a finer points of whether or not she has insulin resistance. Insulin resistance is not very easy to screen for. And this is, again, going back to the measuring tools. If she is blatantly pre-diabetic, it's really easy and obvious. But a lot of women who look completely normal can still be horribly insulin resistant. And their body is just compensating so well. It's keeping blood glucose levels normal, their sugar levels are completely normal, and they only have an exaggerated response to this after they eat. And so you may be able to pick this up in the very early stages. And the earlier you pick it up and treat it, the longer you will delay the onset of full-blown prediabetes and diabetes. That testing is a little bit more difficult. One of the simplest tests is screening with a hemoglobin A1C, which is a measurement of blood sugar and really reflects diabetes. But however, by the time a person develops diabetes, there's good evidence that they have been significantly pre-diabetic for up to 15 years. So I often will do that test first, because if they're blatantly pre-diabetic, then I know the insulin resistance is horrible, it's been that way for a long time, and they need to be treated. If it looks normal, quote unquote normal, then in some of those patients, I will take them back and do more specific insulin testing. And this is really through what's called a glucose and insulin tolerance test. Some people will have a fasting insulin level. Fasting insulin levels are not very accurate at all in determining insulin resistance. Again, if it's elevated, sure, they have it. If it's just because it's normal, though, they don't pick that up till a later finding. So what we really see with the earliest stages of insulin resistance is an exaggerated response in response to an oral feeding. So a person may have normal insulin levels, and once you eat, your body puts out insulin to help your body use the sugar that's coming in. But in people who are insulin resistant, the body spikes a tremendous level of insulin in order to accomplish the same job. So they can have more normal fasting levels, but then have very elevated levels post-meal. And it often takes those levels longer to reach back down. So it's a little more complicated testing. The mainstay for that is really when I have a person that I suspect they may be insulin resistant, but they look normal in the initial screening, and we're talking about really maximizing their long-term health, I may put them through that more aggressive testing. It's not always needed, though. So treating the insulin resistance is one of the mainstays. The first line has always been metformin. Metformin is a medication that's been around since the 60s. But it has slightly different mechanisms of actions that aren't exactly understood how it works, but it increases this sensitivity of the body to insulin. It works in different pathways. It works in the liver. It works in the muscle. And so there's different ways it gets to have its full effect. Metformin is pretty benign. It's safe. Complications are very rare. There can be side effects. Some people may not tolerate it because of gastrointestinal issues. But if they use the slow release form, which I really think everyone should use a slow release form, it's definitely much more tolerable. There's been a lot more evidence of chemicals called inositol, myo-inositol, and D-chiroinositol. These are compounds that have kind of insulin sensitizing qualities. They are really defined as supplements. They're not really prescription. And there's more and more evidence, and there's been a lot of evidence published this year that it can really have a role in PCOS, both in women even having an additive role on top of metformin or in women not using metformin, and it may also help fertility. There's some newer studies coming out that says it can be independently helpful for that. So that's the mainstay of medical management. Now, I do warn those people that when the time comes that they want to conceive, they most likely will have difficulty. And I see many women that are diagnosed with PCOS at 29 or 30 because they've been on a birth control pill their whole life, and it's been covering up their cycles. And they never knew they had irregular cycles till they come off in an attempt to get pregnant, and their cycles are irregular. So people with PCOS will generally, this will be a lifelong issue. They do not usually regulate out. The caveat to that, and with PCOS, is that we do have this group of women who are very obese. The women who are obese get there in a slightly different pathway. They get there more through that insulin resistance pathway. And so often when they were younger and closer to normal weight, they may have cycled regularly, but they generally may have had a tendency to be irregular. But once they gained weight, became more insulin resistant, particularly with a family history of diabetes in a parent, they then become in a PCOS environment and become irregular. In those women, if they can lose a significant amount of weight, and it's been shown just 10% weight loss can often reinitiate their menstrual cycles. However, my experience is that those people always have that tendency. And though they may be cycling normally, they still may not be ovulating regularly. When a person has irregular cycles, if she's having a cycle, and a normal cycle should be between 24 and 35 days. Those are about the extremes. A lot of people think a 28-day cycle, but really 26 to 32 days is more normal. But once you start getting above 35 days, then that indicates you're not ovulating regularly. 35 days is considered the 99th percentile, meaning that of women who are at 35 days, only about 1 out of 100 may actually still be ovulating. So in women who are going 40 days or more, they're clearly not ovulating. But large studies have shown that in women who report cycling, having regular periods, they may not be ovulatory. As much as 1 in 4 women who do not ovulate regularly report having regular menstrual cycles. They usually have different consistencies of how they onset. A normal menstrual cycle should be fairly sudden onset and be heavy the first couple days and then taper out over a few days. I also tell patients a regular menstrual cycle should have at least a little bit of cramping. It doesn't have to necessarily be painful, but a menstrual cycle should never be painless. And many women who don't ovulate will have these painless bleeding episodes, and they often just gradually taper in and taper out. That's very typical of a non-ovulating cycle. So once we've secured the diagnosis, when the woman comes to me and says, I would like to get pregnant, we start thinking about a couple things. So when I see a woman wanting to conceive, one of my first questions is it safe for her to conceive? So if she's not been screened for blatant diabetes, I want to make sure she's not overtly diabetic. And I usually just do that with a hemoglobin A1C. Many women come to me already on metformin, and that's fine. Whether or not some people need it or not, it tends to never hurt. It may have a shade of benefit, and there's newer evidence that using the myo-inositol and D-chiro-inositol can have benefit independent of metformin. So very, very recently, as these studies have come out, I've now started to recommend that as a supplement, even in people that I think may not necessarily need metformin. But once I've secured the diagnosis, then the plan is to start inducing them to ovulate. One of the simplest ways to do that is keep them on a birth control pill. And I tell them you should stay on a birth control pill anytime you're not trying to get pregnant. And as soon as they come off a birth control pill, I will immediately start ovulation medication. The old adage of the birth control pill needs several months to wear out of your system is not necessarily true. Actually, because it's kept the hormones in check, when you come off a birth control pill, it is usually the best time for you to ovulate. Because the longer that a woman is off a pill, these hormones will start to increase again. And that increasingly can make it difficult to get her to ovulate. So when it comes to ovulation induction, there are several different medications we use. A lot of people are familiar with the old classic of Clomid. Clomid has been around since the 50s. And Clomid can work in some women, but there are a lot of women Clomid does not work in. Across the board with the doses of Clomid, about 2/3 of women will actually ovulate with clomiphene. Clomid fools the brain into thinking that the ovaries are not working. Thereby, the brain increases the signals to the ovary. It starts yelling at the ovaries, which helps induce a follicle develop. But in many women, it may not work. Many times, a lot of patients have tried Clomid with their general gynecologist and for a short number of days, and they may not respond. One of the medicines that we've been using really throughout the majority of my career, I've not used Clomid very much. My mainstay is Letrozole. Letrozole has a lot of benefits over Clomid. All studies have shown that the difference in success rate is very little if they ovulate to Letrozole or Clomid, but it favors Letrozole a shade. Letrozole has a lot less side effects than Clomid. Clomid is notorious about causing hot flashes or sometimes mood changes, and Letrozole rarely does that. So Letrozole has less side effects. It's slightly more effective in getting pregnant, but it's significantly more effective in getting a woman to ovulate if she does not respond to Clomid. So only about 2/3 of women will respond to Clomid, but with Letrozole by itself alone, about 85 to 90% will respond. And with the addition of other medications that we often use, I can generally get almost everyone to respond to just oral medical therapy. There's a lot of tricks, and this is used and has taken years and a decade of experience since coming out of fellowship of using doses that are higher than what was initially normal and for longer courses. Many women are initially given a course of 5 days, and 5 days barely gets anyone started. Some women will respond very easily. Some women respond very easy to ovulation medicine, but other women, if they're not an easy responder, they can be very difficult. So often in those women, we'll use much higher escalating doses, particularly if they're obese, and for much, much longer courses. I commonly started 8 to 10 to even 12 days, and I have several women who've had kids that only ovulated after 20 days of medication. Letrozole works to achieve the same goal. It gets the brain to yell at the ovaries, but it gets there in a slightly different manner. Clomid blocks the brain from seeing the estrogen. Estrogen feeds back to the brain and serves as a brake mechanism. So Clomid blocks that brake, and then the brain starts yelling at the ovaries. Well, letrozole actually temporarily lowers the production of estrogen. So instead of fully blocking it, which often leads to the side effects, it actually lowers it. And estrogen is often made in excess in women that are overweight, and so it tends to work better in these women. Clomid is fine if you ovulate to it, but in general, it has a lot less side effects. It's not as successful in getting you to ovulate. Actually, this day and age, letrozole is actually cheaper than Clomid. And one of the concerns is that with Clomid is quoted to having a fair risk of multiples. Multiples is never a goal of ours. It's always a complication. And in a woman with PCOS, multiples greatly elevates the risk of pregnancy complications. Clomid is generally quoted to be around 10 to 11% risk of multiples. With letrozole, general studies show that quote to be more around 4 to 5%. My own experience is at 6 to 7%. So in general, you have a lower risk of multiples, less side effects. It's more effective in getting difficult women to ovulate. Overall, it may be slightly more effective in achieving pregnancy, and it's cheaper. So in those cases, the majority of the time, I don't really have a reason to choose Clomid. There are some extenuating circumstances that get complicated. So letrozole is my main go-to. There are some women, though, that even with higher doses of letrozole don't respond real well. And those patients can benefit significantly, in my experience, from the addition of a steroid. Classically, studies use dexamethasone, but in my experience and some of my former partners' experiences, we have had a lot more success using prednisone. And the reason that this helps, you don't use it all the time. That can cause significant complications, but you only use it during the days that you're taking the ovulation medicine. The male hormones come partly from the ovaries, but partly from the adrenal glands. You cannot manipulate the adrenal glands very much or for very long. So when you take prednisone, it very temporarily lowers the male hormone production from the adrenals. And this really increases the response to a person who's been difficult on letrozole. So many people, until I first know them, I'll do just letrozole by itself at a moderate dose, and then play that by ear once we figure out how they're responding. And we do that by looking with an ultrasound, wanting to see follicle development. Then we'll either adjust the dose, titrate the dose, add prednisone. Prednisone cannot be used in a woman who's fully diabetic, as it drastically can interfere with blood sugars and raise blood sugar. So in some of those patients who can be difficult, it really does leave us in a catch, because that's one of my favorite tools in a difficult patient. Very rarely do women not respond to oral medication, in my view. And in some of those women, they have to resort to using injectable gonadotropins, FSH, or what's called minotropins. And the idea is that the oral medicines get the job started, but they don't quite cross over this threshold they need to get to achieve an ovulation. So you push them over that threshold. The difficulty with those, and why I do not like to use them very much, is because they're very difficult to control and they're very expensive. And the majority of the people, if you use extended courses of medications and hormones, can achieve an ovulation with just oral medicine. My own personal experience is that well over 95% of people will ovulate with oral medicine alone. I only have to resort to, out of forcibly having to resort to injectables, once a year or less. But they can be used, but they get very complicated because many of these people Some of them have a very high threshold, so it takes an enormous, and particularly if they may be obese, and it takes an enormous amount of medications to get them to achieve that one ovulation. So it starts to quickly not become cost effective. But many people, as soon as you cross that threshold, there's a narrow window in which you get 1 or 2 follicles, and if you go over that a little bit, you develop 9 or 10 follicles. And that, so it gets very uncontrolled, and that is not safe. It greatly raises the risk and multiplies the risk of multiples and complications. So it's my personal view that gonadotropin should not really be used in the vast majority of PCOS patients. It's not needed if the other medicines are titrated. Once we get a person to ovulate, I tell women that, though this kind of sounds silly, my experience is that it's either very easy to get them pregnant or very difficult. And there often is not a lot of middle ground. There are many women, and it's very hard to predict who this is. There are many women, be it thin, be it obese, be it bad PCOS, mild PCOS, that once you get them to ovulate, they can be exceptionally fertile. I have one patient that comes to mind I tell patients about that she never had periods ever. And I was able to induce ovulation 3 times and was able to get 3 pregnancies. She was just super fertile and was just waiting to get some eggs out and match it up with sperm. But then there are the other end of the spectrum in women who, despite getting them to ovulate, despite everything looking normal, you can get them to ovulate and match up everything over and over and over, and they just do not get pregnant. Those are a frustration in trying to figure out what's going on with them, because it's really hard to tell what's not working behind the scenes. Obviously, you're able to get them to ovulate and eliminate the timing, even if you look inside and ensure there's nothing going on inside the pelvis. The thought is mainly that they may have issues with possibly the quality of their eggs. There is a subset of women with PCOS. We do see this more with the overweight women that can have egg quality issues. But I have a lot of thin women that actually have very good quality eggs, but just despite getting them to ovulate over and over and over, they are unable to get pregnant. But when a woman first starts, I think if she's never really had a chance before, that she really needs to have a good, reasonable try. A young woman, even in the best of human situations, if her chance each month of trying is somewhere around maybe 20 to 25% a month. So even at that percentage, at 6 months, you would only have about 60 to 70% of them be pregnant. And so I think they need to take time. So a woman who does not ovulate at all and has never used therapy, I would lean towards being a lot more conservative up front and trying a whole lot longer than I often would with a woman who's already ovulating and she's already been trying a couple years. So many of the women with PCOS and irregular cycles come in and say, we've been trying for 3 years, but if you're not ovulating, you've not been having treatment, you may not have ever had any chances. And I kind of say, unfortunately, you've just been wasting a lot of time. So I'd like to get them to ovulate and give them a really good chance. My goal was to really try to get them there as easy and simply and cheaply as possible. But you don't want to waste time, money, and effort if it's not going to work. This somewhat depends on age. A younger woman with good ovary function has a lot more time on her hands. It's not going to change over time. Whereas a woman that comes in at 39, almost 40 with PCOS, time's more of the essence on her. And so I want to give her a reasonable try. But if she's not successful, then she needs to kind of move on. That moving on, where does that go to? There's not a lot between getting you to ovulate and putting everything together and going to in vitro fertilization. IVF is always the fastest way to a pregnancy, but it's not the only way, and it's not necessarily straightforward in women with PCOS. The real gamble when it comes to IVF is about the quality of the eggs and the quality of the embryos that you can make. Many women will do very well. They can make very good embryos with PCOS, but there is a fair percentage of women that have significant quality. The embryo development is not as good, and those embryos don't do as well once you use them. These are very kind of frustrating, and that's why I say IVF is not always a straightforward option. In my view in a lot of those patients, if they do ultimately have to go to IVF, you do have to be careful with them. There's more standards of care of the type of stimulation protocols we put them through. There are some places that do more old school stimulation, which greatly raises the risk of complications. We try to get as many eggs as we can healthily get out of a woman, but some women with PCOS tend to have high ovary function, which means that they can over-respond. One of the things I alluded to earlier is that a woman needs up front to have her ovarian function checked out. I see many women that the assumption is made because you have PCOS, your ovaries will be high functioning, and that does not always hold true. We definitely see a lot of women that still don't ovulate but have very low ovary function, and so you don't want to ever make that assumption up front. But as a whole, most women tend to have slightly higher than normal as far as in the quantity of eggs that a person can make. When they go through the IVF process, you have to be very careful to stimulate them, that they can overstimulate. Some of them have a high threshold to begin with. So if you stimulate them too little, you often end up with a very small group of eggs, 4, 5, or 6 eggs. Whereas you want to stimulate them enough to get a good number. We would like to get 16 to 18 eggs. But if you're not careful, they can overstimulate. And this was a significant complication in the past called hyperstimulation syndrome. Hyperstimulation syndrome, we had difficulty in controlling it in the past, and it could lead to significant health issues and be significantly threatening medically. This day and age, we have ways that we've been able to eliminate the vast majority of it, but you still have to go into the stimulation with some semblance of conservativeness to make sure you want to get a good number. We're always greedy, but you don't want to threaten her health with it. Once we get those number of eggs, these women are usually fairly high responders. So the more standard of care nowadays is actually making the embryos and freezing all of those embryos, because she will have these super high hormone levels, often 20 times normal levels in their body. And those levels have been shown to impair the ability of an embryo to implant in the uterus. So by freezing those embryos, it helps us prevent this hyperstimulation, as well as we see our best success down the road when we come back in a more natural cycle that more mimics what the body would normally do to transfer the embryos back. In many cases, especially in my view, as a woman gets in her pushing mid-30s and above, it can be very helpful to do genetic testing or pre-implantation genetic testing of those embryos. The benefit there is that of all the embryos that you make, not all of them will be genetically normal. And you're sometimes just picking ones, and it's hard to judge which ones are normal. In a woman who has PCOS, they're at a higher risk of pregnancy complications, so we would tend to use only a single embryo. And it's somewhat of a gamble to get to the normal embryos. So the pre-implantation genetic testing in a woman who will make a good number of embryos, it can weed out the ones that are not normal and have no chance of making a pregnancy, and it really gets you to the good ones faster. Because we typically will do a single embryo transfer one at a time, it'll actually be more cost effective in the long range to doing that, because by the time you would have came back a time or two and paid for using the frozen embryos, you probably would have paid for the genetic testing up front. So you end up seeing a higher success rate and a faster time to pregnancy and a lower miscarriage rate. That really applies at any age. We don't do it as much in her 20s, but I think really as a woman gets above 30, it can be significantly beneficial. It's especially beneficial in a woman who has high ovary function as she gets above her mid-30s. But PCOS is a frustration. We know women with PCOS that do go through IVF, they are at a risk of having not as good of outcomes. We know that in general, the embryo development is lower. We know the percentage of women who have euploid or normal embryos is slightly lower. When you put back a euploid embryo, pregnancy rates are slightly lower. There's always been debate about miscarriage, and it's debatable. A lot of the miscarriage data applies to women who are overweight that do have a slightly higher risk. But we know that PCOS, and particularly more so if there's obesity related onto it, really doesn't do as well in IVF. That's frustrating because it's not well understood. The real question is, well, what can I do to mitigate that and limit those risks? And the real question is that we don't really know for sure. probably definitely treating some of the prediabetes and insulin resistance probably helps. Some people have theorized suppressing them with birth control pills for several months to get the hormones in a more normal range, but there's not good data to suggest that that could be a significant benefit. A lot of people question weight loss. Well, unfortunately, the best studies that we have that have looked at intensive weight loss therapies to help women lose weight, they're able to lose weight, but it unfortunately does not seem to change outcomes. If she is a smoker, that is by far the worst thing a patient can do to themselves, and lowers fertility by 1/3, so that's unquestionably out. She really should eliminate all alcohol in the month preceding the IVF cycle. But it's very frustrating. I tell people I understand about weight. I tell people if weight loss was easy, we would all be skinny. And I have struggled with it in my life. But even in this situation, I tell women, I want you to be healthy. I'm not so as concerned about the weight. We do have a weight limit for IVF, and a lot of that is based on the ability to sedate the patient for an egg retrieval and be able to retrieve the eggs. There are some patients that we physically can't get to the ovaries. But the patients that are candidates for IVF, I want them to be healthy, but I can't tell them that there is good evidence that losing a significant amount of weight will help the outcomes much. That is just not true. There's some data that women who have bariatric surgery who are morbidly obese that can help some aspects, but that's partly because there's such a severe starting point. But it's very frustrating. PCOS is a lifelong disorder. I find it to be very frustrating in women because it changes their metabolism. They do favor weight gain very easily. And so some women, even those that are super active and really obey strict diets, can gain weight at the drop of a hat. And that's difficult to overcome, and that will be a lifelong battle. But I think the idea is trying to maximize your long-term health if you're not trying to get pregnant. If you are trying to get pregnant, inducing ovulation, making sure there's no other factors such as tube factors, male factors, pelvic factors such as endometriosis, and giving them a real good conservative try because they really need chances. But we know there's similar success rates, upwards of about 6 of any therapy we do. Once you start getting in the 7 or 8 range, you start to get a diminishing returns. But I think 7 and 8 a lot of times sounds like a lot of cycles, but in a woman who has never ovulated before, has never really had a chance ever, that's very reasonable to do before going on to really more aggressive options. And like I said, they really then have to jump to more aggressive options such as IVF. Well, I've not quite lost my voice yet. If you're still hanging out with me, I appreciate it. And we probably have some time to take some questions that my helpful friend Julie has put together for me.
You may have answered this question, but we have 3 people asking, is PCOS genetic?
There is definitely a genetic tendency. Women who have mothers that have had irregular cycles, they are at a much higher risk of having it. There are some women that have PCOS that no history in sisters or mothers, but there's definitely a genetic tendency. So when I have patients that sometimes are having a baby, they're having a daughter, and they say, should I be worried about them? And I say, it's something to think about and watch them in the teenage years, because there definitely can be a genetic tendency. It's kind of what we term a multifactorial disease, in that there's not a single defined issue. There's not a single genetic defect, and it's multiple factors over time.
Brandy wants to know what dose progesterone, well, if her progesterone was 0.1, what dosage of Humira would you put her on?
Well, progesterone only tells us that a person ovulated or they didn't. There is no proper level of progesterone. Progesterone fluctuates in the body. So it's generally considered that a level above 3 indicates that she ovulated. If she does not, it's really a guessing game. I have to take into account her weight in dosing, as well as kind of if she'd tried other medications. Usually I would pick a middle of the range line of Letrozole. Usually I prefer longer days rather than shorter. I think they work much better. And then I tell patients, when we start, you really have to play it by ear. I tell them that first month can be a very good learning process. Once you usually establish what works for a patient, I find most of them to be very consistent. But it can take a month especially in the first month, of tweaking them. Sometimes when they come in for an ultrasound, the follicles are ready to go, but sometimes they're part of the way there and they need to go for another 4 or 5 days. Sometimes it looks like nothing is happening whatsoever, and we have to up the dose, shift gears, and almost like you're starting from scratch.
Are you familiar with the keto diet being the best diet to lose weight, and do you think it could reset your system to help PCOS?
Weight loss never hurts. I know it's never easy. And I tell people if there was a single diet that worked, there would be one book called The Diet, and there wouldn't be all these different diets. The problem is, with all diets can be helpful. Very few are known to be harmful. Is some concern about the Atkins for long-term health, but all of them can be helpful in weight. The hardest thing is maintaining both the weight loss and maintaining the strict regimen of the diet. We know that because there is insulin resistance, a lot of it is the problems are management of carbohydrates. Carbohydrates is a big enemy in weight. And so I think any diet that restricts carbohydrates is the best as far as it comes to weight. But it comes down to carb restriction and calorie restriction. Many women that have PCOS have a lower metabolic set point that they need in order to gain weight. All of us know people. I have a stepson that can eat fast food every day and pizza every day, and he never gains a pound. And other people, can't. Some women have to feel like with PCOS, they're starving themselves just to maintain weight, and that's very difficult. But any of the diets that are low carb, and this includes both the Mediterranean, which is very good, the South Beach, but any other of the carbs, the keto diet, the harder part is maintaining if you have a complete lack of carbs, you have to introduce them in eventually. And I think something like a keto or a strict carb restriction can be very helpful to stimulate initial weight loss. A lot of people can lose weight really quickly, but you ultimately have to find a balance. And that's what it really comes down to, is a balance that works for you long term. But there's no one diet that's any better than another for fertility. And like I said, unfortunately, the largest studies that look at weight loss for fertility, I think it's still not a bad idea because it can reduce pregnancy complications. But as far as getting pregnant, it does not seem to have that much of a benefit. Now, women who are overweight that are difficult to ovulate, if they lose weight, it can significantly improve that. I've seen patients that were the ones that failed over and over and over, and they were significantly morbidly obese, took time to lose weight, and they came back and they responded much better and seemed to maybe have a better chance, but the IVF data doesn't support it so far.
Is there anything that you can do to lessen hair growth caused by PCOS?
The mainstay treatment is jumping on it. The earlier the better. If you're not trying to get pregnant, trying to suppress the hormones with a birth control pill, and then using androgen blockers in spironolactone as the first line, and finasteride. If a woman has significant hair growth, I will go ahead and use both of them. I tell women hair growth is so bothersome to anyone that, I would fight it hard. Sometimes you feel like you're fighting a losing battle, but I would make sure I go kicking and screaming and doing everything you can. At least if you're suppressing the hormones as much as you can, blocking them as much as you can, then you have to kind of rely on some of the other treatments like laser. But that's the best thing you can do. And the goal is not necessarily to make it better. The main goal is, and that doesn't sound right, but the main goal is to keep it from getting worse. Because no matter how bad you have it, it can be worse. I have some women that have to shave 3 times a day and in a couple of days, will have a full-blown beard. And so that's what I never want to see a person end up with, because that's generally been from years and years of lack of treatment.
What is your go-to for patients with insulin resistance who cannot tolerate metformin at a therapeutic range?
Well, with metformin, we know the highest effect is obtained a little above 2,000 milligrams per day. That a dose of 2,000 milligrams in standard release metformin will almost never be tolerated by anyone. So we know that if you split the dose, doing a morning and evening dose greatly improves the tolerance. Using the extended release version greatly improves the tolerance. In my experience, about 90% of women can tolerate it if they do those two things. There are still some women that won't tolerate full doses. In those instances, I think it's important for them to still use as much as they can tolerate, be it maybe even 500 milligrams. 500 milligrams has a very low drop in the bucket effect. More so at 1,000 a day, more so at 1,500 to 2,000 is ideal. Usually if we're using metformin, I tell patients I want you to get the most effect of it. So I'm not going to give you 500 milligrams. Either use it or don't. And I tend to try to push them to 2,000 a day, 1,000 twice a day. If they don't tolerate it at all, then those are really the main people that you have to go different routes. If they have significant, first I question, do they really need it or not? I have some patients that are so minimally insulin resistant that it's probably not helping that much. Its benefit is proportional to how bad you are in the first place. But this is really where there's some evidence that using myo-inositol and chiro-inositol can be very helpful, and it's generally tolerated very well. If they're not trying to get pregnant, then those people I would use the other insulin sensitizers, what's called a GLP agonist, which are things like Byetta, exenatide, Victoza, liraglutide. These are not recommended to be used in pregnant women. There's not enough data, but in the non-pregnant state, it can be very helpful in these women who are significantly pre-diabetic and really need help, but are just intolerant completely of metformin.
Okay, Stacy says, I've been trying to get pregnant for over a year. I'm pre-diabetic and I have PCOS symptoms. Where do I start?
Well, the most important thing, if you have PCOS and you're not ovulating regularly, you're not really having any chance. So the important thing is to establish a diagnosis. Make sure you're treating the prediabetes to the best of your extent, which really means trying to maximize the metformin. In these cases, I now would recommend the addition of myo-inositol and chiro-inositol has a significant benefit in addition to metformin. And then starting with ovulation induction to get them to ovulate. Because until you're getting eggs out and putting it together with sperm with proper timing, you're not having a chance. And so those are the first steps. And then you have to just take it step by step and see where that gets you.
I'm going to let you read this question from Deidre.
Okay.
People want that answer.
Here's a question. Is it okay to take a multivitamin and the myo-inositol and D-chiro-inositol if I'm trying to conceive? Absolutely. Multivitamin is always a good option. The myo-inositol, chiro-inositol are separate molecules. Most of the supplements put them together now. There's still some studies that have looked at dosing. The Mainstay, there's several. I was just looking on last night and researching this. There's several that can be found on Amazon. The typical doses that's being used it comes in 2,000 milligrams of myo-inositol and 50 milligrams of D-chiro-inositol. So most of the supplements have both of them together. And most people take those once a day or twice a day. One of the simplest things when you look at price of them, prices around, it's relatively cheap, about $20 a month. One of the ones that I often will use is one called Ovasitol, Ovasitol. It's made by a company that I like their products called Theralogics. I'm not paid by them. But it comes down to, especially I think you can get a discount if you get it through our office, but it comes down to about the same $20 a month. And it's a little powder that you just dissolve, has zero taste, dissolve it in a liquid twice a day. And it has that combination. But there are several over-the-counter supplements you can find on Amazon easily that have that 2050 and using that once to twice a day. It's not really clearly been established. Can you take too much or not enough? But that can definitely be used. It can definitely be used with metformin. And I think it's very helpful. And we don't really have data about using it in pregnancy yet, but definitely up to the point of pregnancy, it's very good.
I'm going to ask you two questions at one time. Do you know anything about the supplement Vitex and if that can help you get pregnant? And also, would PCS cause you to get skin tags? And if so, how can you manage that?
Pre-diabetes and insulin resistance can definitely be associated with a stimulation of skin tags. That is an insulin issue. It's also a family tendency. Patients can also develop something called acanthosis nigricans, which is a darkening of the skin in the groin area and inside of the thighs and under the arms. That is usually can be a sign of the presence of insulin resistance. So in those patients, you treat that as much as you can. Skin tags are if a person is still making them, you just have to have them treated, frozen off, cut off. But there's a family tendency, but that's something we think about if a person has a lot of those. Are they insulin resistant? The Vitex is a supplement that there's not as much research. It kind of goes along the same way. Whether it helps you get pregnant or not, there's no good data. I don't fault a person for using it. It's never a bad idea. Whether it's something magic, no.
Okay, one more question.
One more question.
And of course, we'll answer any that we don't get to after. But Jenny wants to know, have you seen studies that point towards the benefits of giving up gluten and dairy in women with PCOS?
Gluten and dairy is always it's been the in vogue thing to do. There really isn't any good data to suggest that makes a difference. Yes, it seems to be a fad. Now, a lot of people who are giving up gluten are giving up carbs. But if you substitute gluten, which tends to be more, the wheat-based carbs, which are carbs, but not the worst carbs. And if you substitute that with many of the gluten-free foods substituted with sugars, and sugar substitutes and fat substitutes, you're probably going to make the whole process worse. And dairy as well. Dairy does have sugars in it, but there are a lot worse things. I think a person can definitely have gluten and dairy as part of their normal diet. If you feel like eliminating it makes you feel better, then there's not that much harm to it. But as far as would I say you need to go gluten-free or dairy-free, no, absolutely not. That wraps up most of our questions. I appreciate anybody that's held out for me. And sometimes I start rambling, and I just like to share the knowledge I have. So we are always here for you. We have offices in Columbia with our partners, Dr. Tarnawa and Dr. Corrine Frew, and in Greenville and Asheville with myself, Dr. John Nichols, Dr. John Payne, and also an office in Spartanburg with Dr. Payne and Nichols. So if we could ever be of any help to you, please feel free to reach out with us, and I hope you have a good night. Thank you.